Dear colleagues and friends in Kazakhstan, it's a great pleasure to be with you for your national meeting today. Sorry I can't be with you in person, and hope we have a good session together. I've been asked to talk about the challenges to meeting the physical and psychosocial needs for palliative care patients, in particularly with reference to the CIS countries. I'm Dr. Stephen Connor, the Executive Director of the Worldwide Hospice Palliative Care Alliance, an alliance of almost 400 organizations in over 100 countries that is dedicated to including palliative care in national health care. So we'll proceed with this session. First, to say I don't have any conflicts of interest to declare, except that my interest is in palliative care development globally and the Worldwide Hospice Palliative Care Alliance. So today, in the next half hour, we're going to talk about the status of palliative care and also psychosocial issues, in particular bereavement support and challenges for the bereaved globally, both in Kazakhstan and other CIS countries and globally. We'll talk a little bit about the challenges we're facing in terms of COVID-19 and other challenges we face to achieving universal health coverage and access to medicines, etc. Also, I wanted to share with you some early recommendations we're working on for governments to improve their end-of-life and psychosocial care that we hope will be enacted following, hopefully following the pandemic. So much of this information I'm sharing today comes from the Global Atlas of Palliative Care, which is our publication with the World Health Organization that paints a picture of palliative care worldwide and helps to address some key questions about palliative care globally, including who needs palliative care and what some of the challenges are we're facing. So overall, the need for palliative care has grown considerably, at least roughly 60 million people. That's, we had estimated in the Global Atlas about 57 million, but that number's increased due to COVID and also aging of the population and other issues that have increased the need for palliative care. Most of the people who need palliative care have non-communicable disease. We'll talk about that. And live in low and middle income countries, more than three quarters, almost 80% of the need in low and middle income countries, when we have most of our services in high income countries at present. Most are older people, but we also have a need for palliative care for children. At least 7% of the need is for children. And when we care for anybody in palliative care, we always admit the whole family to care. They're treated and are subjects of care as much as our patients. Only at present, we estimate that only about 12% of that need is being met globally, and huge problems with access to medicines, and millions of people literally every year dying of pain. Oops. Back up. Sorry. We're having a little technical problem here. There we go. So also, we want to talk about grief, because whenever anyone dies, whether they had palliative care or not, their family and those that love them are going to experience grief. About roughly 60 million people die every year on our planet, and there are various estimates to the number of people that are grieving following a death, but one source puts that at 5 people per death. That comes from from a survey that was done in the U.S. Census. That was pretty accurate, though we've seen as high as 9 sometimes in terms of numbers of grieving people per death. But if you use that figure, you're talking at least around 300 million people a year who are grieving. And we now have a new condition in the Diagnostic and Statistical Manual for Mental Health Disorders called prolonged grief disorder. And it's estimated that roughly 4% of people grieving will have prolonged grief disorder, and that gets you to over 12 million people likely. We'll talk about prolonged grief disorder later in this talk. And also, if you think about it, on average, around 16 people attend either a funeral or a memorial service for every death that occurs. And that really means that about 1 billion people a year attend a funeral in our world. So what do people die of globally? Mostly non-communicable disease, as we said, about 75%, but also injuries, communicable diseases, mainly in particular HIV and TB, but also children, infants with maternal and perinatal and nutritional conditions. These are the top 10 one of the lists of top 10 causes of death, with heart disease at the top and stroke and infection, COPD, etc. But these are many of the causes or the needs for palliative care: Alzheimer's disease, TB, and some injuries also appropriate for palliative care. So we have about 7 million people receiving palliative care. This, as we said, only about 12% of the need, from about 25,000 palliative care services. That's actually up from when we did this research back in 2011. This is as of 2017. And back in 2011, we had about 16,000 services serving about 3 million patients. So we are actually making some progress in terms of palliative care. You can see in the darker shade color countries that those have more delivery of palliative care services. We see some countries little or no delivery. And we have very sporadic, access to palliative care. About 64% of countries have with very limited access to palliative care. And palliative care is mainly for older persons, as we said, biggest category of 70 plus, but also children needing palliative care. These were the 20 diseases that were the main causes of need for palliative care, including cancer is 28%, or roughly around 30% of the need. So really the need for palliative care is mainly for people with non-cancer conditions, and some communicable disease like HIV is a significant portion, and TB. But we see heart failure, we see organ failure of various kinds: liver, kidney, brain, if you will, and lung disease and such. But the situation is a bit different for children. We have the biggest cause for children, actually right now still is HIV, primarily concentrated in the African region. But for children, birth trauma is a big issue, congenital anomalies, congenital malformations, injury is a significant one, and various other illnesses. Only 4.1% of the need is actually for cancer. And mainly people in low and middle income countries, 24% in high income countries. The need is predominantly, and this is a kind of almost 80-20 problem where we have most of the services in high income countries, but most of the need in low and middle income countries. And I think it's our task in the decades coming to try to reverse that so that there's much more access to palliative care. The focus should be on palliative care in low and middle income countries. So what about Kazakhstan? We divide the need for palliative care almost half and half into those who need palliative care at the end of life or in the year that they will die of their illness, and those who are called non-decedents who need palliative care prior to their last year of life. we know that palliative care needs start oftentimes a couple of years before the death occurs, sometimes longer, many times shorter. But we broke for Kazakhstan down that need for adults and children separately. Almost 5,000 children and over 100,000 adults. So the need is over 100,000, 107,000 in Kazakhstan. In the other CIS countries, you see the similar sort of breakdown of roughly half and half in terms of decedents. And Armenia, 23,000, Azerbaijan, 49,000, 95 in Belarus, 100,000 almost in Belarus. Kazakhstan, 107,000, Kyrgyzstan, 26,000. Moldova, we didn't get data on, I'm afraid. Russia has the biggest need, of course, almost 2 million needing palliative care. And in Tajikistan, 29,000, Uzbekistan, more, 118,000. This is roughly reflective of the fact the size of those countries in terms of population. So let's talk about a few of the other challenges we're facing to meet this big need for palliative care: the COVID situation, universal health coverage, access to medicine, and recognition within the healthcare system for palliative care. We did a survey in late 2020 of the impact that COVID was having on palliative care and universal health coverage and during COVID-19. We found that over 75% of the programs around the world were having either moderate or severe disruption due to COVID-19. And of course, this is before we even experienced all the problems we're having in Ukraine now with the war and displaced patients. Many top palliative care patients have had to leave the country and are being cared for in some surrounding countries like Poland or Moldova or Romania. But a pretty big impact on the delivery of palliative care in these countries. Sorry, these slides are progressing slowly. So we've seen a lot of disruptions where people with palliative care are not getting palliative care. Units are being closed, operations disrupted. Governments are not integrating palliative care into the COVID-19 response. And the financing for palliative care has been disrupted. A lot of the funders that are now funding COVID-19 problems or other emergency needs. So palliative care programs that rely heavily on charitable support are not getting the funding that they need. And many have had to close actually and lost their ability to operate. One of the key things we're trying to do is get palliative care included in universal health coverage. The UN Sustainable Development Goal for Health and Well-being calls on all countries to have access to palliative care in universal health coverage as part of the continuum from prevention to promotion to prevention to treatment to rehabilitation and then to palliative care. If you don't have palliative care as part of your universal health coverage in a country, you're not actually having universal health coverage. And so we're keen to monitor and to look at every country's universal health coverage plans. They're supposed to achieve that goal by 2030, and it's looking like it's not going to be achieved, though progress will be made. And we want to make sure we don't forget palliative care when countries are developing universal health coverage. And we need help from not just ourselves, but we need other allies within healthcare to advocate for palliative care as well as ourselves. So it's a kind of a dual-edged sword. I mean, we've seen that we've had disruption to palliative care units operating, people being reassigned to work on COVID patients. That's lessening now a bit. Funding is diverted. And we also are going to see, we expect, because of a lot of the problems when patients were in ICUs, that families couldn't visit, they couldn't care for the patient. Funerals and memorials were disrupted because they wouldn't allow group gatherings during the pandemic. And this is going to result in an increase in the number of complicated bereavement cases we see. But also at the same time, it's really forced, I think, the healthcare system to recognize that palliative care is an essential part of healthcare. One of the more, most important concepts in ICUs have been palliative care workers, including chaplains and others, and they really begun to see the value of palliative care and why you need people who are trained and dedicated to caring for these most seriously ill patients. So another big challenge we're facing still and continues is the lack of access to opioids. And it's a dual crisis because we have in the US and Canada and Australia an ongoing problem with excess overdoses from opioids. And but the real problem is that, the vast majority of people needing opioids for pain control are not getting them. 90% of the world population only consumed 11% of controlled opioids in recent years. That means, that 10% of countries were using almost 90% of all the opioids. There's 10% of those countries in dark or red in this map. But really, access to opioids is so heavily restricted that it really is still almost a bigger problem. It is a bigger problem than the problem with misuse or overuse of opioids in some countries. So globally, when we look at the consumption of opioids, we can see that these are the main opioids tracked by the International Narcotics Control Board, and they're the ones that are this data is reported on. The green top line is methadone. And while we use methadone as a second line treatment many times in palliative care for pain relief, its primary usage globally is for substitution therapy for opioid use disorder treatment. And so we sort of put that to the side when we look at consumption really for pain management. And we see the pattern here, which we've seen a big spike in the use of fentanyl. It's come down a little bit now. Been pushed pretty hard by the pharmaceutical companies. Morphine consumption has remained fairly steady during this period, not up a lot. I'd like to see that start to come up more. And the other opioids are generally not that available besides fentanyl and morphine. Codeine is being discouraged now because of some problems with side effects, and pethidine, of course, is not considered appropriate for palliative care patients at all. Anyway, for Kazakhstan, similar pattern. We see methadone increased considerably just in this past couple of years, as well as morphine. And I would probably say this has to do with, in Kazakhstan, with success in terms of expansion of palliative care services throughout the country and increased education of prescribers around use of opioids for pain control. But it's still very little. It's less than 4 milligrams per capita. The global average for morphine is around 5 milligrams per for all opioids, sorry, not just for morphine. And so we have a long way to go in terms of achieving some standardization in terms of what a population needs per capita in terms of opioids. This is the morphine consumption. Oops, I think this is a repeat. Sorry. So we now, as we develop palliative care globally and try to overcome these challenges, we have a new public health model for palliative care development that was developed. We worked on with the World Health Organization when developing a set of indicators for countries to use to measure palliative care progress. And we encourage all countries to use those new measures. from WHO. But we had before a kind of a triangular model with policy at the top, with education and medicine availability, and then implementation. But we've added to this model the importance of empowering people and communities, that palliative care is everyone's business, and that we have to encourage and engage with communities around palliative care development to create a kind of extra layer of support for people when they're seriously ill and needing palliative care. We certainly need the health policies, and those health policies come about when we have evidence, good evidence for why palliative care is needed. And of course, essential medicines and education and training is those two have to happen in parallel. If you train people about opioids and palliative care, and they don't have an opportunity to access opioids, then they'll forget what they learned. If opioids are made available, but people aren't trained in how to use them, then they're not used. So it's got to be a parallel process for education and medicine. But the education is a bigger piece, in the sense that we need literally to train millions of people to meet that need for 60 or so million people a year needing palliative care and their families. And then we can't do that by having standalone palliative care programs. We need them integrated into healthcare systems. So they should be part of your primary care delivery system, the polyclinics and other primary care providers, for that to be effective. So, as I mentioned, we need to partner with other organizations, with cancer societies, with the Alzheimer's disease people, with all the different organizations that are concerned with care of the patients that we care for. And we sometimes have to make a little noise, I think, to get the attention of government to act up a bit and demand and say this is a human right and people have to have access to palliative care. We are building an evidence base for palliative care. Almost everyone agrees these days that palliative care is better care for people when they're facing the end of life than traditional or standard care. It really has to be integrated, both at the community level, but also sort of bottom up and top down from the community, and from support from political leaders. We need political will for palliative care to succeed. I had mentioned that we also, from a mental health perspective, when we talk about the psychosocial needs of people in palliative care, we're talking mainly around grief. That could be grief for families prior to the death, and for patients when they're dying, as they lose their abilities and function over time. And we also then see, particularly after death, that every family grieves in their own way, one way or another. We have, and this is a bit of a controversial topic, because we don't want to pathologize grief or suggest that grief is abnormal in some way, but we do see a distinct kind of difficulty for a very small percentage, probably less than 5% of the population of people grieving in a given year will experience what we're calling now prolonged grief disorder, which should last. The criteria with the DSM-5 and the ICD-11 is it's got to last for more than a year. So in the first year, you're going to see people with intense grief, but if it's persistent and pervasive, not if it's just normal grief lasting more than a year, there is no time limit to how long people grieve. They grieve, you grieve for someone your whole life many times, but these are people who are really stuck in their grief. It's persistent. It's they can't let go. They can't move on. They are constantly in pain and yearning for the person, and have at least 3 of the 8 additional symptoms. Either they still are in a place of denial where they can't accept and believe that it actually happened. They believe the person still may be alive, or intense emotional pain, or feeling of confusion around their own identity, serious avoidance of any reminders of the loss, feeling numb and disconnected from the rest of the world, being intensely lonely, losing a sense of meaning in your life, and difficulty engaging in ongoing in your life in an ongoing way. These are the sort of symptoms of this that would suggest that that person needs more than just the support of their friends and family. There is a tool called the Prolonged Grief Disorder PG-13 scale, which can be used to help identify people with possible prolonged grief disorder. This you can look this up easily in terms of the scaling or 30 points for someone who has concern for prolonged grief. We're also putting a focus this year at the World Hospice and Palliative Care Day on grief and loss. The theme for this year is going to be healing hearts and communities, and it's really about, you know, all of us needing to heal after the last 2 years of the pandemic and the experience of grief that a lot of us have felt, not just for losses, but for the sense of normality in our daily lives. And the need to heal from this is something that unites people everywhere. You know, helping ease this grief, this increased burden of grief is important. Having a healthy grief experience is essential. Most people have resilience and will be resilient and can get through this, but we need the support of communities and some degree of professional support. There are good cognitive treatments for prolonged grief that can be taught to mental health professionals. I'll just share with you a few thoughts about patients. Now, this is a gentleman that we knew, and it's important that the people who are living with palliative care needs can advocate for palliative care. Now, Joseph was a lovely gentleman in Uganda who had colon cancer and was having a lot of depression and difficulty because of lack of dignity. Because of his lack of resources, he was unable to get colostomy bags. And so it wasn't until the palliative care service got his pain under control and helped provide him with the equipment he needed, the supplies he needed, that he was able to feel that he could speak for himself and speak for the importance of palliative care. And Joseph was with us in Uganda, telling his story and sharing his story from the hospice that was caring for him. And he did die about 2 months after this picture was taken. But a real impressive gentleman. This young woman is a woman I spent time with in the palliative care unit in Kyrgyzstan, in Bishkek, who was the only patient on the palliative care unit who had who knew her diagnosis and prognosis. She was a kind of a strong, independent woman who insisted on being told. But this is early days in Kazakhstan, where we were, Kyrgyzstan, where he was, where we were, training the palliative care folks to more effectively communicate with patients about their diagnosis and prognosis and telling the truth. Anyway, she just was a very, I thought, strong example of someone with the courage to want to know. This gentleman with the glasses in the foreground is Dr. Christo Huta, who's the foremost palliative care physician in Albania. And one of his patients was a pancreatic cancer patient we saw who had depression, and we were working with him and his family to help address some of the causes of his depression and help him with medication as well as treatment. But just to say that these are the patients these are the reasons that we need palliative care and why we do the work we do, is to make sure our patients are accessing palliative care and getting the support and relief of suffering they need. We did do some policy recommendations on grief. I know I'm running out of time, so let me wrap up here. National strategies are needed for how countries deal with grief and loss. They should use public education campaigning and provide support to the bereaved, and particularly for those with more severe reactions, mental health treatment. We believe in compassionate communities, and we want to help build compassionate communities, which are an essential way of putting that extra layer of support around people with palliative care needs. And so we were recommending that, that there be investment in development of community support for palliative care. So our challenges are, as many of you know, to increase education for all the healthcare professionals, that to integrate palliative care into primary care, we need to educate all health professionals, increase especially our capacity to deliver home-based care, make all patient accessibility, make all medicines that are essential for palliative care available, accessible, and affordable, and involve the community more in the care that we provide. Because palliative care is a kind of model really for the future of the healthcare system. It's really because most of the patients have palliative care needs, have non-communicable disease. We're really kind of a model for how best the healthcare system should change in the future as the population ages. I'd like to thank you very much for your kind attention, and wish you every good wish for the conference this year, and hope to see you again before too long in the future. Take care of yourselves, do good work, and keep in touch. Bye for now.